Thank you for joining us today for the CEU presented by Behavior Brain Magazine and ABC Behavior Training. Today we are going to be looking at ABA and trauma, how to apply trauma-informed care to our practice. This CEU is being presented by myself, Melissa Druskis. I'm a board-certified behavior analyst since 2015, and I am the owner of ABC Behavior Training and the founder and editor-in-chief of Behavior Brain Magazine. Today we're going to be covering some content from two articles. You definitely should take a look at these ahead of time if you're able to, or if not, then looking at them later on would also be fantastic. It's going to give you a better grasp of the content that we're talking about today. And these two articles are listed here. First one is toward trauma-informed applications of behavior analysis. And then we also have an article, Assent in Applied Behavior Analysis and Positive Behavior Support, Ethical Considerations and Practical Recommendations. Now, let's get started looking at trauma in ABA. So we know that there is a growing awareness of the importance of trauma-informed care across many disciplines, but it has received less attention in behavior analysis. So we're going to look at the causes for this gap, how to address these barriers, and then practical strategies for us to be able to implement trauma-informed care into our practice. So first, let's take a look at the barriers in ABA. And the first article I talked about identifies 3 barriers. The first one is conceptual confusion and interpretive difficulty. So understanding trauma within behavior analysis. Now we've went over a good deal of what trauma is, so hopefully you now have that good understanding. But this can definitely be a barrier when it comes to trying to incorporate these concepts into what we already do. So external causes versus internal responses. So trauma results from external events that are often severe or aversive, but the trauma is conceptualized in terms of internal psychological states, such as fear, helplessness, loss of control, and betrayal. So even though we acknowledge that private events occur and that's a part of radical behaviorism that we all follow, we oftentimes find ourselves focused on observable behaviors. So we are looking at things that we can see ourselves and other people, that are measurable by ourselves rather than internal states, even though these still are considered behaviors. So that challenge with internal states, like feelings and perceptions that are associated with trauma, often seem subjective to us and not directly observable to us, making them difficult to address within a behavior analytic framework. But again, these things are still behaviors. They're still within what we would be looking at as far as private events versus public events. There's also difficulties in defining what a trauma response is. So we have looked at what that means, but it does lack oftentimes a precise behavioral definition. Because of this, there's really no specific set of observable behaviors that universally define a trauma response because it's variable for each individual. Individuals may exhibit a wide range of behaviors in response to trauma. That can include avoidance, aggression, or psychological changes or physiological changes like increased heart rate. And then language and terminology issues. A lot of the talk around trauma, describing trauma, it's not led by behavior analysts. So a lot of that language does include mentalistic terms that are not easily, changed into terms that are objective and concrete. So having that can be a little uncomfortable for us as behavior analysts. We feel uneasy using these terms that cannot be directly measured or observed or that start going into that realm of mentalistic terms. But again, if we look at the individual, if we look at what is happening with that individual person, we can turn these mentalistic terms into actual behaviors that we can define for that person. So we don't have to be afraid of those mentalistic terms. We can just pivot them into behavioral terms once we have the experience to do so. So also some implications for practice. Avoidance of trauma discussions. So oftentimes there can be a hesitation to engage in discussion about trauma due to the conceptual confusion. We may avoid addressing trauma altogether and just not even talking about it or getting information about it. And that's going to be a missed opportunity for us because that avoidance can lead to missed opportunities to understand the full context of a client's behavior. We want to look at the full picture, including any traumas that have occurred in their history. And there is that need for a functional definition. So, a focus on behavioral correlates. Developing a functional definition of trauma that emphasizes observable behaviors can make the concept more accessible. So, we definitely should focus on that and alignment with behavior analysis. So, a behavioral focus that's going to allow trauma to become incorporated into assessments, interventions, all of those things that are consistent with behavior analytical principles. Basically, we need to take this concept of trauma that's often talked about and dealt with mentalistically, that we don't have just really clear definitions for, that it's not very concrete for us. And we need to have more behavior analysts working on this. Start talking about it, start using it, and let's, as a field, start introducing these concepts into our field so we don't have that conceptual confusion, that we can overcome those mentalistic terms and still be able to utilize this in our therapy and help people by understanding the full range of what's going on with the client's behaviors. So just an example of what this could look like in real life. Maybe a child punished for spilling. So there could be a child who has been beaten and abused for spilling something in the past. They may learn to suppress exploratory behaviors or show heightened fear responses. So, behaviorally, we're looking at avoidance of similar situations. They could be having increased anxiety in the presence of potential punishers or aggression as a defensive response. And without acknowledging the trauma or without knowing about these trauma, these behaviors might be misinterpreted and not fully understood. We could be doing things to address these behaviors, which ultimately are going to create more trauma for this child instead of looking at what the actual cause of those behaviors are. Another barrier is an emphasis on current contingencies over historical causes. So as behavior analysts, we absolutely should be looking at the whole picture, the whole learning history, but many times we are focused on what is happening right there in that moment. So we can prioritize factors that become directly observable and altered in the present environment. And this allows for a practical interventions that can produce immediate changes, but we still want to look at the whole learning history because past experiences, including traumatic events, those are going to contribute to an individual's learning history, but they are less accessible and they are harder to quantify, but we still should be looking at that. And also, there's that risk of oversimplification. So, if we're ignoring the learning history of our clients, that may lead us to oversimplify the causes of behaviors, just looking at, in the very immediate history of maybe why that behavior is occurring. But if we're not looking back far enough, we're missing out on some potential causes of these behaviors, potentially leading to less effective interventions. There's also challenges in integrating trauma history. So, assessment limitations. A functional analysis, again, is often going to be concentrated on identifying immediate antecedents and consequences of behavior. And there also may be insufficient integration of the client's history into the assessment process. So, obviously, we do ask about some history things, but they are often not really related to trauma. Maybe they're related to like their communication history or when did this behavior start. But many times, unless you're actually asking pointed questions about potential trauma, you're not going to get those as an answer because parents may not even connect that to the behavior. And then when it comes to treatment planning, so treatments may be designed based solely on the current contingencies without considering how past trauma influences behavior. And if we're not taking into account those trauma histories, we could inadvertently trigger negative responses and potentially re traumatize that individual. So, implications for practice. So, ethical considerations. We need to make sure that we're considering all relevant factors, including historical ones, to provide effective care. And if we're incorporating trauma histories, this can lead to a more comprehensive understanding of the client's needs and where these behaviors are coming from. It's also going to help with effectiveness of interventions. So, recognizing that trauma as has occurred can inform the development of our interventions that are more personalized and potentially more effective. And the client may respond better to the interventions because it acknowledges and addresses the past influence of trauma and avoids re traumatizing them. So, an example here, if you have a child that has a history of neglect, some behaviors that you might see is that they exhibit aggression that is reinforced by adult attention. So, if we are not looking at this history of neglect, if we're not looking at this trauma, we might implement extinction by withholding attention to reduce the behavior. But if we are providing a trauma informed approach, we can understand that the child craves attention due to past neglect and suggest that providing consistent positive attention proactively might be more effective and humane than further traumatizing them by creating a further withholding of attention, which is something that they have already experienced through neglect. And then the third barrier that was talked about is lack of widely accepted evidence based practices. So there is a proliferation of trauma informed care frameworks out there, but they're not often done by behavior analysts. So there are some core principles that they look at. Safety, trustworthiness, choice, collaboration, and empowerment are all common themes in trauma informed care frameworks. But different disciplines and organizations are going to adopt various interpretations and practices under this umbrella of trauma informed care. And there is some evidence limitation. So, the systematic reviews, they often reveal a lack of high quality research demonstrating the effectiveness of these interventions. And a lot of times it's focused on staff outcomes. They look at how the staff knowledge or attitudes are changed over time rather than client outcomes. Challenges for behavior analysts with this. So, there is a strong emphasis on evidence based practice supported by rigorous research in our field. We need to provide evidence based treatment. So, without solid empirical evidence, we might be hesitant to adopt trauma informed practices. But also, we want to look at and think about we are not the ones that have been doing a lot of that research. If you're looking at social sciences, their requirements for research and what they look at is going to be different from ours. So we need to have practices that can be operationally defined and measured. But we can absolutely do that with the research that is out there and also by conducting more research within our own field. So, if we're looking at trauma informed care and the frameworks that are already out there, the research that's already out there, instead of just taking it just as it is, we should take those principles and translate it into specific and behavioral interventions that are within the framework of ABA and our work as behavior analysts. And then taking that step up to putting more research out there that can show behaviorally how these trauma informed practices can benefit our clients. So, implications for practice with this barrier. Potential resistance. We should be self aware of the resistance that we may feel or that our colleagues may feel when it comes to incorporating trauma informed care practices. due to this lack of clear evidence-based guidelines. But without integrating these practices, we may miss opportunities to enhance our practice and improve client outcomes. And it also, like I said, is an opportunity for contribution. We are in a great position to contribute to this research with evidence-based research that is, at our standards to validate these trauma-informed interventions. And then we can also incorporate interdisciplinary collaboration. So working with professionals from other disciplines can help our understanding and application of trauma-informed care principles and how we can incorporate it into our work. So an example here, Maynard et al. 2019. So they did a review of trauma-informed care in schools and found no studies meeting the rigorous inclusion criteria. And really, this highlights the need for more robust research to support these practices, but it doesn't mean that we shouldn't include these things in what we're doing. There is a lot of studies out there that do show the importance of it, and we should be implementing these things and doing the research and putting it out there to show how trauma-informed care and trauma-informed practices are very vital for our field as well as the other fields that have taken on this trauma-informed approach and put it into practice in these various disciplines. So some opportunities in ABA when it comes to implementing trauma-informed care, just kind of summing up some of those barriers and things that we should be doing as behavior analysts in this regard. So we should be contributing to trauma-informed care. Our expertise in empiricism and precise definitions is really valuable. We should be taking this information and focus on creating observable behaviors that we can define to address trauma. We should be integrating trauma histories into our assessments and our treatment planning and our parent interviews and all of that. And we should also be advancing research. So, conducting studies to provide empirical support for trauma-informed interventions and demonstrating improved client outcomes through behavior analytic practices. So now let's move on to some things that we should be doing as behavior analysts to incorporate this trauma-informed approach. So the first thing is going to be acknowledging trauma. We need to recognize trauma's role in behavior. Current behaviors may be adaptations to past trauma experiences, and understanding that trauma is going to help us in interpreting and responding to these behaviors appropriately instead of just looking at what's going on in that moment. And our behavior analytic perspective. So environmental factors are going to be exerting control over trauma-related responses. Shared stimulus properties between the past and present environments can trigger responses. So an example of this is maybe you have a client that has a history of physical abuse, and they may react really intensively to mild physical prompts. If you don't know about that history of that trauma, you're not going to be able to connect what was going on in the past and those reactions to the present environment and why that's triggering now maybe aggression or just whatever that intense reaction is. Also, recognizing individual differences in trauma responses is important. Not everybody is going to respond to trauma in the same way. So some factors that can influence that is their personal history, their pre-existing traits, the environmental context, all of those things. We're not going to have just, if somebody was neglected, they're going to exhibit these behaviors. No, it's completely different for each individual person, and we need to acknowledge that. And then also we should have a caution in assumptions. So we need to avoid generalizing trauma responses. Just like everything else in behavior analysis, everything is individualized. Just because a child has autism, they're not going to have the same responses or skills that they need to work on. It's the same for somebody that's experienced trauma. So we may need to make sure that we are not overgeneralizing in our clinical decision making and that everything is individualized. We also need to know that there is probably going to be undocumented trauma histories. There are high rates of adverse childhood experiences, which is those ACEs. And there is an increased risk among individuals that have intellectual and developmental disabilities, and also our clients with autism. So, even though you might not have a documented history of a trauma, it doesn't mean that a trauma didn't occur. Also, communication barriers can impede this as well, because our clients, if they have limited ability to communicate trauma experiences, then there's a potential that a trauma happened and maybe their parents don't even know about it. So traditional trauma assessments might not be effective if you have somebody that can't communicate those experiences. So having an approach of universal precautions is going to be the most beneficial. Just assuming that there's a potential trauma in all clients, in the absence of concrete knowledge, if we treat all clients as if they may have a trauma history, that is going to be most beneficial because we are still approaching them with empathy, with compassion, with least intrusive measures, which is really what we should be doing anyways. So the benefits of this, it's going to minimize the risk of re-traumatization, and it's going to promote a safe and supportive environment. Even if you have a client that really did not experience any trauma, there's not going to be any negative side effect to approaching them in this way, approaching all of your clients as if there could be a potential for trauma in their history. And then guiding principles. So, exercising caution in clinical decisions, maintaining vigilance for signs of trauma responses, all of those things we should be doing, whether or not we know if there's a trauma in their history or if there is an undocumented trauma. So, some examples of potentially re traumatizing events that we should be aware of in our treatment during ABA services, transitions to residential facilities, or even just transitions between clinics. Staff and peer turnover can be traumatizing, and use of physical restraints or seclusion. Obviously, there may be times where this is needed, but we need to be aware that if we're physically restraining a client, if they're being secluded, if there's an overuse of physical prompts, these things can be re-traumatizing to your client, regardless of whether or not you have documentation that it was necessary. Regardless of the reason, it could potentially be a re-traumatizing event, and you should definitely be taking data around those events and looking for any sort of trauma responses that are coming from it. And then there's also life events that can be traumatizing, so death of a family member, parental divorce or conflict, moving away from familiar environments, transitioning from one school to another, all of those things could be potentially traumatizing events that you may encounter throughout your treatment. And then clinical decision making with trauma awareness. We should be selecting interventions that considers a trauma history when we're choosing our procedures and choosing less intrusive measures whenever possible. Alternative strategies use non-contingent reinforcement whenever you can do so, delivering that reinforcement independent of the client's behavior, and utilizing differential reinforcement without extinction, reinforcing desired behaviors while not using extinction procedures. And again, there are some exceptions. We're going to talk a little bit about when you're working with truly dangerous behaviors, but a lot of our clients, they have behaviors that we're working on, behaviors that we need to reduce, but it's not that it's going to cause them a hospital visit if the behavior occurs, or it's not extremely dangerous to other people. So when we're looking at these things, it's not just one size fits all. We're looking at it on a spectrum of behaviors. So I would say for a good majority of our clients, we can use these alternative strategies. And then we want to monitor and adjust our interventions, continuously assess our clients' reactions, and be prepared to modify our approaches when needed. So ensuring safety and trust, this is another component of incorporating trauma-informed practices into our therapy. So there's physical safety is one aspect of safety, and this is the condition in which an individual is free from the threat of physical harm or injuries. So some behavioral indicators here is a lack of avoidance or escape behaviors, engagement in the activities without distress or fear. So maybe there's a client that's participating in their sessions without attempting to leave or showing signs of agitation. That's demonstrating that they have physical safety. And then there's also emotional safety. So this is the state in which a client or an individual feels secure, valued, and able to express themselves without fear or negative consequences. So what this might look like is that they're open communication and willingness to interact. They display trust towards their practitioners. So maybe you have a client that's sharing their thoughts or feelings with the therapist and seeks support when needed. Even your nonverbal clients can demonstrate this just through their physical actions too of how they are interacting physically with their team of therapists. So safety signals in the environment. So there are some operant conditioning of safety signals that we can do. These are environmental cues or stimuli that have been associated with the absence of aversive events. These signals can reduce anxiety and promote approach behaviors. So we can create these safety signals by consistently reinforcing, providing positive reinforcement in specific settings. So thinking about pairing. So pairing your environment more to signal that it is a safe environment. We can do this through predictable routines and predictable responses from therapists. So, behavioral outcomes of doing this, you should see increased engagement and cooperation, a reduction in avoidance or escape behaviors. Now, the impact of unpredictable threats. So this is going to be related to contextual anxiety. So this is anxiety that arises from environments where threats are unpredictable. So this is not what we would want to see in our sessions, but you should be aware of it because you could be seeing this if you don't have a safe and trusting environment, or you could be seeing it at home if there's unpredictable threats there, or even in a school environment. So, some effects of behavior here, it's going to be heightened vigilance or hyper arousal, increased avoidance or defensive behaviors, and there is a particular risk for individuals with ASD. They're going to have heightened sensitivity to uncertainty. We know a lot of our clients, they like predictability, they like certain routines. So when things are uncertain, when there's unpredictability, they might be more sensitive to it than kids that don't have autism. So some behavioral manifestations of this, what this might look like, is repetitive behaviors or rituals to regain a sense of control, and also resistance to change in routine. And then some behavioral strategies that we can utilize to promote safety. So, consistency and predictability. So, having clear routines and expectations, providing advance notice if there's going to be changes. So, using a visual schedule to outline the day's activities, and also minimizing aversive stimuli. So, avoiding the use of punishment or negative reinforcement, and focus on positive reinforcement to encourage desired behaviors. So, providing reinforcement for a client participating in a new activity rather than penalizing them for their reluctance. And then we also want to establish trusting relationships. So that is done through pairing, building rapport through positive interactions, being responsive to the client's cues and their needs. We should acknowledge and validate the client's feelings, whether they are reporting them vocally or if we just see them happening, and promote open communication. They are allowed to feel how they feel, and we shouldn't just be trying to shut it down because their feelings come out as behaviors that we're trying to reduce. So, another important aspect is promoting choice. So, when we're promoting choice, there are a lot of benefits for this. It's really essential in trauma informed care. One benefit is empowerment and autonomy. So we're restoring control to the individual. Trauma can leave people in a situation where they feel powerless. So providing them with choice is going to help restore that sense of control over their environment and their decisions and what's happening to them. And it also promotes self-efficacy. When our clients can make choices, they are going to experience a sense of competence and confidence in their abilities. And that's something that we should be fostering, whether they feel that way when we first start working on these things. You don't want to end up with a client years down the line that's just compliant because they, just follow any rules that are given to them. We want them to be able to advocate for themselves. We want them to be able to make choices and have confidence in their choices, just like you do, just like everyone else does. That's what we should be striving for our clients, that they can make their own choices and that we are giving them the opportunity to do that and the ability to learn to do that comfortably. It also builds trust and safety. It is going to be respecting individual needs. When we're honoring what their preferences are, we're showing them respect, and that is going to ultimately foster trust. And it's also going to reduce that power dynamic. So providing choice, it's going to diminish that gap between the therapist and the client, creating a more collaborative relationship. It also helps in preventing re-traumatization. So, forced interventions can trigger memories of past trauma. By providing choice, it's going to allow them to engage willingly and reduce the risk of re-traumatizing them. Clients can also choose to avoid activities or stimuli that might be triggering for them, enhancing their emotional safety. So, implementing choice in ABA as a trauma informed practice, there's a lot of different things that we can provide choices of. So, that can include a choice of activity and task. We can provide options of multiple things that they could do and let the client select which one they want to engage in. We can also provide choice of a schedule, so letting them have a say in the timing and order of activities. Choice of reinforcer. We're probably all already doing this, but making sure that they are identifying what they find rewarding, what they want to engage in, and make sure that the reinforcers are always meaningful and motivating, that they are actually acting as reinforcers. And then regularly update the preference assessments to reflect these changes. Don't just do a preference assessment at your initial assessment and then never again, because clients' choices are going to change from day to day, and we want to make sure that they have a choice in the thing that they are earning. And if they choose something and, when they get to the end of their token board or however they're accessing that, they may have changed their mind, and we should honor that as well. Also, a choice in goal setting. So obviously, we can't always do this for all of our clients, but if you have a client that is able to be involved in the goal setting, like sitting down at the table for those meetings and, you know, during their assessment, even just asking them what's important to them, we should be involving clients in that, even if they're a young child, like if they can communicate what's important to them, we should be asking them. And then, of course, we should be including families in setting the therapeutic goals as well. But we should be looking at the whole family. So, not just the parents, but also the clients when you can. And then we should encourage our clients to express their aspirations and incorporate them into their treatment plan. Like, what is their goal? Even young kids, there's something that they want to do, that they want to accomplish. And we should be looking at what that is if they can communicate that with us. And then choice of intervention strategies. So we can provide a choice of how we're going to work on things, allow clients to choose their preferred approach. And if they can't do that, like through a conversation with you, explaining these different things, in just a little bit here, we're going to talk about assent and assent withdrawal. And we can utilize that to identify what their preferences are, treat on intervention methods as well. Even if they can't sit there and have a conversation with you about how they want the therapy to go, we can look at that through their behaviors and make sure that clients are agreeing to the interventions being used, even if they're a young child, even if they're nonverbal, there are behaviors that we can look at for that. Also, choice in the environment. So, allow clients to choose where the session's taking place. If it's in a therapy room, outside, in their living room, just utilizing the environment and giving them more of those choices. And also letting them adjust the environment for factors like lighting or noise or temperature to their comfort level. Then we can also have a choice of social interactions. So if group activities are involved, let them choose who they want to interact with, and then also let them decline social interactions if they feel uncomfortable, and respecting those decisions as well. So, importance of assent. As I said, we were going to come to this, but it is our ethical responsibility to respect autonomy, and that includes the client's ability to give and withdraw their assent of treatment. So, every individual, regardless of their cognitive or communication ability, has the right to be treated with respect and dignity. Tracking assent ensures that we are honoring our client's autonomy and personal agency. So informed participation. So while the child may not legally be able to consent, their assent is still crucial for ethical practice. So we want to be looking at and tracking their willingness or unwillingness to participate in the therapy, and that's a really vital aspect of trauma-informed care and person-centered care. So this is going to help, again, we talk about avoiding re-traumatization a lot, but that's really our goal for trauma-informed care. But that's going to help with this because for children that have trauma histories or heightened sensitivity, forcing participation can lead to re-traumatization. So tracking assent is going to help create that safe, supportive environment because we're not going to be forcing them into doing things that they clearly don't want to do. It's also going to allow them to express assent or dissent, and that's going to empower them, help restore a sense of control that may be especially important for those who have experienced trauma. It's also going to, in the long run, enhance our therapy effectiveness because having this respect, it's going to help build that trust between the therapist and the client, which is really important for effective intervention. Some things that we may ask our clients to do might be hard, but they need to have that rapport with us that they know when they do the hard things, they get reinforced for it and that it's a safe environment for them to engage in these behaviors and for them to push themselves and to do things that are a little bit more hard. It's also going to help their engagement. They're going to be more likely to engage and benefit from therapy when they are willing participants. And then there's also legal and professional standards. So, obviously, we have our ethics code, and our professional guidelines emphasize the importance of obtaining assent from individuals who cannot provide consent and respecting their right to withdraw. Also, ignoring signs of dissent can lead to ethical complaints or legal issues, especially if the child experiences harm. And then individualized care. So, tracking assent allows us to adjust our interventions to better suit the child's needs, preferences, and comfort levels. And we can also look at changes in assent, which may indicate shifts in the child's emotional or physical state, signaling the need for reassessment and really looking at what's going on in the environment if you had assent for a while and now you see that that's changing. So let's go over some examples of what assent and assent withdrawal might look like. So vocally, answering yes or some functionally equivalent phrase. Non-vocally, you may see nodding, signals start by touching a start picture icon, touches a yes icon, leans in towards the practitioner or the materials and smiles, reaches for the materials, takes the materials and arranges them for instruction, enters the treatment area, and approaches and sits with the practitioner. So, all of these things, you can physically see with just nonverbal body language that the client is interested in what's going on. they are engaged, they're leaning in. All of those things we can look at for assent topographies. Now, assent withdrawal typographies, vocally, they may be saying no, stop, or any functionally equivalent phrase, word, or sound, negative statements about the task, the therapist, the session, or repeated attempts to talk about a different topic. Now, non-vocally, maybe they're stopping, hitting the stop or all done icon, or signing all done, shaking their head no, ignoring or not responding to the therapist. Maybe they're leaning away or turning their body away from the therapist or the workspace, swiping or throwing materials, running away from the treatment environment, looking in the opposite direction, refusing to transition to or from environments, activities, people. They could be engaging in aggression, self injury, or elopement. So, all of those things are things that we would look for to see if assent is being withdrawn. So, understanding assent withdrawal. So, assent withdrawal, that's going to occur when the learner is indicating either vocally or non-vocally that they are no longer interested in participating in the treatment activity. Forms of assent withdrawal, like we said, there are vocal, verbal indicators, and there's also non-verbal indicators that show that the client does not want to do this anymore. So, why is it important to look at assent withdrawal? We touched on some of these things when we were looking at why this was important, but just to circle back to it, it's going to respect autonomy, promote trust. It prevents harm and re-traumatization of that forced participation. And it's also within our ethical guidelines that we should be respecting our clients' individuals' preferences and rights. So there are some common concerns to this. You may be feeling, am I just giving them an option to get out of work? And yes, actually you are. You are offering them the option to opt out because that is respecting the learner's autonomy. There's worries about noncompliance, of course, concerns that allowing the assent withdrawal may lead to avoidance of tasks and also impact on progress. We could have fear that frequent withdrawal may hinder therapeutic outcomes. And yes, you are going to be working on stuff less often if you have a client that's constantly withdrawing their assent. But there are things that we should be doing to change this to make it more positive for our client. So we should be reframing our perspective. View assent withdrawal not as noncompliance, but as a valuable communication about the learner's need. It also is an opportunity for engagement. So use this withdrawal as a chance to assess and adjust the treatment to better suit the learner. And then also look at the long term benefits because respecting their choices is ultimately going to lead to a willingness to participate over time. If you think about, a client that was in ABA therapy and they're constantly being forced to participate over and over and over again over years, like that's going to make the ABA therapy traumatizing for them. And that's the things that we hear about from people with autism that are now older, and they're saying that they were traumatized by it. They may have been if they were constantly forced to participating in something when they constantly kept saying no, no, no with their behaviors. So there's definitely things that we need to shift our perspective on that and ways that we can adjust our therapy to make sure that we do have their assent instead of their constant withdrawal of assent. So some key things that we need to think about when we're responding to assent withdrawal. One is immediate respect. We should honor the learner's decisions to promptly reinforce the trust. So when it's clear that they are not interested in what we're doing, we should pause and make some changes. And we're going to go over some options for how to handle this next. Also, assessment. So we should determine the potential reason for withdrawal. Are we providing them with a task that is too difficult for them? Or have we moved too far ahead of where their current level is? Is it something that's causing them discomfort? Is there something else in the environment that's going on that's causing this reason for withdrawal? Also, collaboration. So, engage the learner in problem solving to modify the activity if that's appropriate and if it's something you're able to do. And then we should be flexible. So, just prepare to adjust treatment plans to meet the learner's needs. Maybe we can have a couple of plans in place, like this is the plan for this program, but if we are experiencing a lot of assent withdrawal, have a plan B for your therapist to make those adjustments to without you as the BCBA having to be there like every second to make those adjustments. Having a plan B in place is going to give your tech something that they can do if they are seeing and experience a lot of this assent withdrawal. So there are options to handle assent withdrawal. So there's 3 options that we're going to be going over that you can implement. So option 1, do not represent the treatment conditions. So when to choose this option? If there are features causing assent withdrawal that cannot be adjusted within the current session, so for example, if the treatment requires like specific equipment and that's causing distress and there's no other alternatives available, then we're just not going to represent it because clearly this is something that's causing distress for the learner. Also, the intensity of the withdrawal. If the learner's assent withdrawal is really intense and they display significant distress or challenging behavior that cannot be safely managed in the session, then we're going to not represent it again. And then also if there's clear refusal, so if the learner communicates verbally or non-verbally that they do not want to engage in this treatment condition for the remainder of the session, then we should respect that and not represent the treatment condition. So some next steps for this option, we of course want to respect the withdrawal, immediately cease that treatment activity to which they've withdrawn their assent, and provide a neutral or positive response to reinforce that their choice is respected. Also postpone representation. So do not reintroduce the treatment condition during that current session. Focus on engaging the learner in other activities or allowing them to have a break. So for future sessions, there's a couple of options here. So option A, you could represent in the next session, reintroduce that treatment condition as they were to assess if the withdrawal was specific to that session. So you'll get to see like, are they having the same reaction to it this next session? And if not, then maybe it was something that was just specific to that session as opposed to specific to whatever that program is that you're working on. And observe whether the learner response is different, indicating the withdrawal may have been due to something temporary, like just their mood, or maybe they were tired or hungry or something else was going on. So option B, we also can analyze and adjust. So outside of the session, you can analyze the treatment conditions to identify the specific features that may have triggered the withdrawal. And then consider factors like we talked about, task difficulty, sensory sensitivities, or environmental distractions, and then modify the treatment plan accordingly for future sessions. So an example scenario for this, a learner becomes visibly upset during a reading activity, pushing the book away and refusing to continue. Despite attempts to encourage participation, the learner remains distressed. So the practitioner then decides not to represent the reading activity for the rest of the session, and instead they engage the learner in a preferred calming activity, and then later they review the session to identify potential triggers. Maybe it was the content of the book, difficulty, and then plans to adjust for the next session. Now, I want to point out here for this example, it's not like the client engaged in challenging behaviors and you immediately dropped it, because we also don't want to just reinforce any attempts to escape from something and reinforce it by allowing escape all the time. So in this example, you see there are attempts to encourage participation, maybe even attempts in the moment to make some modifications to make it easier. But when you do those things and it's clear that the individual is like not having it at all, that's when we're talking about not representing it. And then you would move to something that can be a calming activity afterwards. It doesn't mean the rest of your session is out the window. Obviously, you can go and do the rest of your programming once the client has calmed down or has moved into more of a neutral state before you move on to something else. So those are things to think about, and we're going to talk about here in just a bit what to do for those severe behaviors that maybe don't fit into the abilities of what we can do in all of these situations. But this is really what that would look like. We're not trying to reinforce escape maintain behaviors, but we're also not trying to force participation. So there definitely is a balance of what that's going to look like. So another option is that we can represent the treatment conditions later on in the session. So we can choose this if there's an unknown cause. So the therapist is really unsure why the learner withdrew the assent. Maybe it is a temporary factor. So there was a loud noise. There was some brief frustration from something else that was going on. There was momentary discomfort. Or like I said, it's getting close to lunchtime and they were hungry, or they just got into session and they had just woken up from, a nap, or they just woke up in the morning. So if it's something like that, that's temporary, and that seems to be the reason why they're withdrawing their assent, then you can represent it later. Also, if it was mild withdrawal, so maybe the learner shows mild signs of withdrawal that they may dissipate over time. So the next steps here is pause the activity, respect the learner's withdrawal by pausing the treatment conditions, whatever that program is. Allow them to have a short break or engage in just some other activity before you go back to it. And then monitor the learner. So look for any signs of readiness to re-engage and make sure that any of those external factors that may have been causing distress have been resolved. So next steps, you're going to represent later in the session. After a suitable interval, you're going to gently reintroduce the treatment conditions without modifications and use positive and encouraging approach to invite the learner to participate, and then see what they do. Are they going to provide their assent and continue as planned, or are they withdrawing their assent again? And if that's the case, you may consider moving on to option 1 or option 3, which we'll talk about in a minute. So an example here, during a math activity, a learner becomes momentarily frustrated and says they want to stop. So the practitioner respects with the withdrawal and suggests taking a short break. After engaging in some calming activity, the practitioner reintroduces the math task later in the session, and the learner agrees to participate and completes the activity without further issue. Now, option 3 is to represent the treatment conditions with modifications. So you should choose this option if you've identified what the trigger is, or you have a hypothesis about the specific features of the treatment that led to the assent withdrawal. Or if there were mild or precursor behaviors, maybe they were just showing early signs of withdrawal that can be addressed promptly. And then also if there's adjustable factors, so features causing discomfort can be modified within the session. So the next steps, if you utilize this option, is to identify the cause. So what about the situation was prompting that withdrawal? And common factors, like we've talked about, can be task difficulty, duration, sensory sensitivity, or just lack of interest. So we can modify the treatment conditions, adjust those identified features to make the activity more acceptable, possibly modifications that can include simplifying the tasks, shortening the session, changing the materials, or altering the reinforcement strategies. So next steps here will be to engage the learner in problem solving, involve the learner in discussing what changes would help them feel more comfortable if you're able to do that with your client, and offer choices and accommodation preferences when possible. Offering the choices here, that's a big one and would definitely help with this because you can offer choices for within that program of what it is that you're working with. And then you're going to represent the modified activity, reintroduce this adjusted treatment conditions, and make sure that they are behaving, showing that they are giving their assent before continuing. And then monitor and adjust. So observe what their response is to the modifications, and then be prepared to make further adjustments as needed.
So an example scenario here, a learner begins to fidget and express disinterest during a writing task. The practitioner notices the task may be too lengthy and the topic unengaging, so they pause the activity and ask the learner if they would prefer to write about a different subject or work for a shorter amount of time. And the client chooses a new topic of interest and agrees to write for a shorter duration. And then the modified task is represented and the client participates willingly. So, like I said, we were going to circle back to what about severe behaviors. So, working with clients who exhibit severe behaviors that pose a danger to themselves or others, that's going to present a unique and significant challenge. So, in these cases, sometimes immediately stopping the intervention upon assent withdrawal might not be feasible due to safety concerns. However, it's really important to still integrate trauma informed care principles to the greatest extent possible to support the client's well being while ensuring safety. Now, this may not apply to many of you out there that are listening to this. Maybe you work and focus on early childhood intervention where you have much younger kids and they don't have very, they might have aggression, but it's not going to cause serious damage to anybody. Or there's mild behaviors, or you're mostly focusing on skill acquisition. But then there's those of you out there that I'm sure you know who you are as you're listening to this, thinking you can't stop your intervention, even if they're showing these assent withdrawal behaviors, where you have clients that, if this behavior continues, they're going to end up in the hospital, or they're going to get seriously hurt, or somebody else is going to get seriously hurt. And those are the severe behaviors that I'm talking about now. If you have, some mild aggression, I'm not including that in these severe behaviors. Then still, let's look at that as a assent withdrawal and go with one of the options that we just previously talked about. But when we're dealing with these severe behaviors, we want to prioritize safety while still upholding dignity. So, safety first. The immediate priority is to ensure the physical safety of the client and other people around them. And this may necessitate the use of interventions even when the client is withdrawing their assent, because we want to keep our clients safe, right? That's still our number one priority. And we can still maintain dignity and respect, even if we can't uphold the assent withdrawal in some specific situations. So, we want to use the least intrusive interventions necessary, have calm communication, speak in a calm and respectful tone, explain the actions that we're taking, not react, in anger or react in a punishing way towards the client in our communication, and also preserve privacy. Implement interventions in a manner that maintains the client's privacy as much as possible, even if that means like moving to, instead of a classroom full of students, moving to a more private room, and continuing to deal with the behavior there. And then we also still want to think about proactive planning and prevention. So, through your FBA, you should have conducted a thorough assessment to understand the underlying functions of the severe behaviors. And that may extend into doing an FA and really looking at those, identify the triggers, the antecedents, and consequences associated with the behaviors. Make sure that you have a behavior plan that focuses on prevention strategies and skill building, as well as safety procedures, and incorporate proactive measures to reduce the likelihood of dangerous behaviors from occurring. And then have an individualized crisis plan. So make sure you have a crisis plan outlining the specific steps to take when the severe behavior arises, and make sure that all staff are trained and consistent in implementing the plan. And we still want to incorporate trauma informed principles into what we're doing. So, offering choice whenever possible, even during the crisis situation. Even if it's something as simple as, do you want to sit here or do you want to sit there? Giving them these choices and involving them in the scenario, even though we can't just stop the intervention because it may be something that's dangerous, it's going to help in creating their safety plan and creating how they want these behaviors, how they want the intervention to go during these moments of crisis. And you can do that during calmer times. So by involving them in this, again, if you're able to, if the client's able to participate when they're calm, that's still going to help when this severe behavior is occurring later, even if they're declining the intervention at that time. Also, explaining interventions before and during implementation whenever it's possible to do that. Use clear, simple language to inform the client about what's happening and why. Again, remaining calm, remaining with a neutral voice throughout that time is going to be really helpful. And then collaboration. So work with the client, their family, and other professionals to make sure that it's a unified approach and incorporate the client's preferences and perspective into the intervention planning. We also want to make sure we are still using least restrictive interventions. There should be a hierarchy of interventions and imply the interventions starting from the least restrictive, escalating only as necessary. Some examples of that can be verbal de escalation, environmental modifications, and physical proximity before considering physical interventions. Avoidance of restraint and seclusion, using that only when absolutely necessary and as a last resort. Unfortunately, as I'm sure many of you have seen, physical restraints used when it was not absolutely necessary or the last resort. So just make sure that if you are using them, you really are looking at the whole picture. Ask somebody else that's not in the situation for their input on it before, incorporating this into the plan. And make sure that we are following legal and ethical guidelines strictly by ensuring that interventions are as brief and safe as possible. And we should have staff trained in de escalation methods to prevent escalation of dangerous behaviors. And that may include active listening, empathy, distractions. Like there's many different techniques that could be used to reduce the severity of the behavior before it gets to a dangerous point. And then we should also focus on skill building and replacement behaviors. So, teaching coping and self regulation skills during non crisis times, focus on building skills that are going to help the client manage their emotions and these behaviors. And then using evidence based practices like relaxation techniques, mindfulness, and cognitive behavioral strategies. Communication skills are really important. Make sure that the client has the ability to express their needs, frustrations, or discomfort appropriately. Utilize functional communication training to provide alternate ways to communicate. And we also may need to use gradual exposure and desensitization, systematically exposing the client to triggers in a controlled manner to reduce their sensitivity over time if it's something that can't be removed from their environment. And then also pair exposures with positive reinforcement and coping strategies. And that brings us to the importance of emphasizing skill building. So, having our focus on building new skills is going to increase your client's willingness to participate. It prevents re traumatization because it focuses on positive, non coercive teaching methods, and it enhances our therapeutic outcomes because it's building that trust and safety and promoting client autonomy. So we want to consider the learner's preferences, interests, and strengths. So we should do that through preference assessments, identify items, activities, subjects that the learner enjoys to incorporate into their skill building activities, and then use those. Strength-based approach, leverage existing skills and interests to facilitate learning new behaviors. So we should be starting where the client is and slowly building upon that based off of their strengths instead of trying to take them from, they're at level 1 at the VB map and trying to take them to level 3 without getting to the things in between. Just make sure that we're building upon existing behaviors and existing skills instead of just trying to focus on something completely brand new when we're starting out. And then also looking at cultural and individual relevance. So make sure that our goals are culturally sensitive and align with the learner's identity and their values. So we should be prioritizing functional skills that enhance independency and quality of life. So one of those is going to be functional communication. So these are skills that give the learner an ability to express their needs, wants, and feelings effectively. That should be reinforced with whatever reinforcement they're getting for their challenging behaviors, giving them an alternative way to express themselves. Daily living skills is also another important area for skill building, self care tasks such as dressing, hygiene, or meal preparation, where the introduction of another person may increase behaviors, frustration, other things that we don't want to see. We want them to have as much independent skills as possible, and daily living skills is a big area for that. Social skills also interacting appropriately with others, sharing, taking turns, understanding social cues, and then academic and vocational skills. So the skills that are needed for success in an educational setting or future employment. Obviously, we don't teach a lot of academic related stuff, but there are skills that are needed for the educational setting that are not necessarily just like math and reading and things like that. And we should be focused on those skills that are really going to set them up for success instead of making those situations more difficult for them because they don't have some of those skills. And we also want to think about acceptable short term alternative behaviors. So, immediate behaviors that serve the same function for the learner as their challenging behavior, but that are more appropriate, require minimal effort, and are socially acceptable within the learner's context. So, we're looking for functionally equivalent alternative behaviors. It should achieve the same outcome as the challenging behavior. So, if the client is engaging in a behavior to escape from the task, we need to give them another way that they can escape from the task appropriately without this challenging behavior, such as by asking for a break or, hitting a break icon if they're using an AAC device. It also should be minimally effortful. So it should be easy for the learner to perform without extensive training. Ideally, you want it to be easier for them to perform than the challenging behavior is. It should be something that they prefer to do because it's easier and gets them the same reinforcement. And then it should be contextually appropriate. So it should align with the social norms and expectations in the learner's environment. We don't want to teach them some random behavior that nobody else is going to understand to access this reinforcement using this alternative means. So it should be something that people can understand really in any setting. So with all of these things that we've talked about, this is really going to give you a good path that you can follow to incorporate trauma-informed practices into the therapy that you're providing through creating, a safe and trusting environment, providing choice, tracking those assent and assent withdrawal behaviors, understanding how to utilize this with severe behaviors that might not fit most of what we see, and also emphasize on skill building. So there's a lot that we could delve into these different realms, like how to do functional communication training, what goals that you should be working on. But that is something that we can cover in another talk. But just for now, as we're talking about how to implement these things in our ABA practice, this is going to give you a really good overview of things that you can do and take into your therapy tomorrow and start implementing to make sure that we are looking at this picture and we're acknowledging potential traumas and that we are focused on not re-traumatizing our clients or creating a trauma in our clients by utilizing forced participation.
Thank you so much for joining me today for the CEU. Be sure to click the link below to get your CEU certification, and I look forward to seeing you all next month.